This is the sixth in a series of presentations on radiography of joint disorders in veterinary patients. The intent of this presentation is to describe and provide examples of the various manifestations of elbow dysplasia in the dog. By the end of the presentation, you should be able to list the underlying causes of elbow dysplasia, evaluate radiographs for signs of elbow dysplasia, and identify the radiographic abnormalities of and diagnose each underlying cause of elbow dysplasia. Excellent diagnostic quality radiographs are needed for evaluation, and those radiographs should be properly positioned lateral and craniocaudal views. However, there are supplemental beneficial views when evaluating the patient for elbow dysplasia, and in fact, we include all 4 views in our elbow dysplasia radiographic package. And those supplemental beneficial views include a flexed lateral and the craniolateral caudomedial or pronated views. We talked about the pronated view in the presentation on osteochondrosis in the dog. Knowledge of normal elbow anatomy is going to be of paramount importance as we start to look for the abnormalities that we see with elbow dysplasia. And I feel that this is something that is really important for you to know because evaluation for causes of lameness localized to the elbow is very common in a small animal veterinary practice and likely almost as common in a mixed animal veterinary practice. This slide is just showing us a refresher on the normal anatomy of the canine elbow. And the elbow is somewhat complex, so I thought it was beneficial to go through this again with you. On the left of the slide are the unlabeled lateral and craniocaudal views. On the lateral view, don't forget the big bones. We've got the humerus, we have the ulna, and we have the radius. And then specific to the elbow, down here in the distal humerus, we have the condyle of the humerus. We also have the medial epicondyle, as well as the lateral epicondyle. And then on the ulna, we have the proximal part of the ulna, which is the olecranon, and there is a tuberosity of the olecranon. But then an important structure also on the cranial part of the olecranon is the anconeal process, or the anconeal process. We have the trochlear notch of the ulna, and then superimposed over the radius is this very important small part of the ulna, and that is the medial cornoid process. The dog does have a lateral cornoid process, which is back here, but that is not part of disease usually. And then the radial head is another area that we're going to be looking at. On the craniocaudal view, specifically looking at the medial side of the elbow, this is the location of the medial cornoid process of the ulna. So again, very important. We have the medial humeral epicondyle and the medial aspect of the humeral condyle. And then this is the olecranon tuberosity, and this patient's a little bit oblique, so we see a little bit of that anconeal process, but this view is not very good for that. And then, of course, the radial head is over here. So it's really important for you to know those normal anatomic structures so that we can look for our disorders. The flexed lateral view can be really important, and that's for a couple different reasons. This happens to be a young patient. Notice that there is a physis here of the medial epicondyle of the humerus. So that is a separate center of ossification. So in the kind of standard lateral view here, if that physis is still open, and that usually closes around 8 months of age or so, if that physis is still open, it could cause us to be confused by what's going on with the anconeal process. It's superimposed over that anconeal process. On this nice flexed lateral view, then, we take that medial epicondyle of the humerus and its open physis in this younger patient, and it is no longer superimposed over that anconeal process. This view is not the only view I want to get, though, because it makes it more challenging to evaluate the radius and the radial head. It also is more challenging to evaluate for any soft tissue swelling that might be present in the elbow. Elbow dysplasia is a very nonspecific term, and it refers to a variety of developmental lesions in the canine elbow, which then lead to the development of degenerative joint disease or osteoarthritis. The developmental lesions that I expect you to diagnose include medial cornoid process disease, ununited anchial process, and osteochondrosis of the humeral condyle. We have already discussed osteochondrosis of the humeral condyle, and you should review the presentation on osteochondrosis in the dog as part of this elbow dysplasia presentation. All of these lesions may be due to osteochondrosis. However, asynchronous growth of the radius and ulna and the proximal ulnar dysplasia resulting in kind of an abnormally elliptically shaped ulnar notch have more recently been suggested as potential implicating factors in the development of elbow dysplasia. It's also important for you to recognize that one, two, or all three of these primary lesions may be present in the same animal. So just because you identify one of the underlying lesions of elbow dysplasia doesn't mean that you should stop evaluating. And as I said earlier, even though we're talking about elbow dysplasia as kind of a group of disorders, what I really want you to be able to do is diagnose the actual underlying condition. Now, when I look at an elbow in a patient where I am trying to decide if the patient has elbow dysplasia, it can be really helpful to initially assess for evidence of secondary degenerative joint disease as a clue that the patient has elbow dysplasia. Certainly, it's true that secondary DJD may be non-existent or mild in the younger patient or the patient that has really mild findings, but it is important to evaluate the elbow initially just to have a clinical suspicion that we should look even further. So ultimately, as I said, you do need to evaluate for the underlying common disorders of elbow dysplasia. So you do need to know those common underlying causes and where to look for the radiographic abnormalities. So in a patient that has degenerative joint disease that is secondary to elbow dysplasia, there are certain sites where I will look for the kind of osteophyte production. This is a flexed lateral view of the elbow of a dog that has degenerative joint disease secondary to elbow dysplasia. And one site that we want to look at is the kind of proximal or cranial aspect of that anchial process. So the anchial process margin is this more sclerotic line, and this patient has smoothly marginated osteophyte production. We can also find osteophyte production on the radial head. So here's the radial head. Here's a large, smoothly marginated osteophyte, a little more challenging to see in this extreme flex lateral. They will also develop osteophytes on the medial epicondyle of the humerus. So here is a smooth margin of the medial epicondyle, and here is osteophyte on the more distal aspect. And then, not evident on this view, we can look for osteophytes and changes on the medial cornoid process. But on this view, another area to assess is that trochlear notch of the ulna, and this patient has a lot of subchondral sclerosis, which is a finding in degenerative disease. Typically, for normal, and you can look at normal, you'll just see a thin rim of subchondral compact sclerotic bone, and we'll be able to see more lucent bone with this nice fine trabeculation going up toward the articular margin. So we're starting to see blurring of that. This is just an example of the unlabeled and then shaded sites of osteophytosis affecting this elbow. And then this is a craniocaudal view of a patient with elbow dysplasia and secondary osteoarthritis. And on this view, we'll be able to identify the osteophytes on the medial epicondyle of the humerus and some osteophytes on the medial cornoid process. So again, this is the medial side. I know that because the ulna is more medial than the radius up in the elbow. We're not going to be able to see osteophytes typically on the radial head because they're on the cranial aspect. We're not going to obviously see the anchial process, and we're not going to be able to identify the sclerosis of the trochlear notch of the ulna. And then again, this is just our unlabeled and shaded example. Let's start with medial cornoid process disease because this is the most common underlying cause of elbow dysplasia. You may also hear it called fragmented medial cornoid process or even medial compartment syndrome or compartment disease. Clinical signs typically develop in affected patients around 4 to 6 months of age, but we don't usually see the radiographic evidence of this disease until about 7 to 8 months of age. And in fact, some patients may not even show much for degenerative joint disease at all, or they may not show it until several years of age. The medium to large breed dogs are the ones that are affected, although this slide lists several breeds that are at risk, and you can see those breeds. Other large breeds can be affected as well. And interestingly, up to 75% of the cases present in male patients. Oftentimes, both elbows will be affected. I really do want you to understand the radiographic findings that you can look for and the sites and places to look for them for this disease, because again, this is a most common cause of elbow dysplasia. On the lateral view, we're going to be able to look for a couple different things. So the first thing that I like to look for is remembering where that medial coronoid process is. That should be a nice discrete triangle of bone that is superimposed over the caudal part of the radial head. So on this lateral view, we can see if we can see that medial coronoid process well, or as in this case, it looks like it has an abnormal contour or poor definition, so I really can't see it very well. On this view, then, the only other things we might be able to identify would be our secondary degenerative joint disease. This patient has a small amount of osteophyte proliferation on the proximal aspect of that anchineal process, and probably a little bit of sclerosis of that ulnar notch. On the orthogonal view, or the craniocaudal view, we again are going to want to look at that area of the medial coronoid process of the ulna, and oftentimes it will be abnormally shaped like this one is. This one has kind of a blunted and rounded abnormal shape, also probably has some osteophytes, and I want you to compare this to the normal. And then again, we might be able to see the secondary degenerative joint disease, where I can see some osteophytes here along that medial humeral epicondyle. Now, an osteochondral fragment associated with the medial coronoid process disease is possibly identified, but that is fairly rare. And that is because sometimes it is still cartilage, or it is really partially attached to the ulna, so we don't see it as a separate fragment. Most of the time, our diagnosis of medial coronoid process disease is actually made indirectly by identifying the secondary degenerative joint disease that accompanies this primary lesion, and then ensuring that we don't see the other causes of the elbow dysplasia. So that would be our osteochondrosis of the medial aspect of the humeral condyle that we've already learned about, and the ununited anchineal process we'll learn about later. Radiographs can be not very sensitive, especially in detecting the fragment, as I already said. And so CT is actually routinely used now to diagnose medial coronoid process disease. Here's an example of a patient where we have lateral and craniocaudal views. And when I look at this lateral view, this patient probably does have some intracapsular soft tissue swelling of the elbow joint. Again, that can be more challenging to identify. Looking at the lateral view, I want to ensure that I look at that area of the medial coronoid process, and in this patient, it is ill-defined and somewhat abnormal in its shape. It looks kind of flattened or blunted. This patient also has some sclerosis of the trochlear notch of the ulna, and then has a little bit of smooth osteophyte proliferation here on the proximal aspect of that anchineal process. Very minimal change maybe on the radial head. On the craniocaudal view, I do see that this area of the medial coronoid process is very abnormally shaped in its kind of contour. It's kind of rounded. It also probably has some osteophytes. And then the medial epicondyle of the humerus has some osteophytes as well. And then it's not uncommon for us to see soft tissue swelling of the medial compartment of this elbow joint, which I think I see in this patient as well. This is a different patient, and these are not the best exposure radiographs, but do show the lesion that I wanted to show you. So the lateral view, a little bit underexposed. On this view, it's somewhat challenging to see the area of the medial coronoid process. It looks a little bit indistinct. There's probably some sclerosis of the trochlear notch of the ulna. There's a small irregularity from osteophytes on the radial head here, and probably a little bit of osteophytes on that anchial process, which are unfortunately somewhat superimposed by the medial epicondyle. But all of these findings are pretty subtle. And in fact, on the cranial caudal view here, the area of the medial coronoid process actually looks pretty okay, and I don't see any irregularity of that medial humeral epicondyle. So pretty minimal changes to be helpful on the standard orthogonal views. But then we want to add in that pronated view, or that craniolateral caudal medial view that we learned about in the osteochondrosis evaluation. And when I do that view on this dog, I can actually now see that there is a radiolucent line that is separating a small osteochondral fragment of the medial coronoid process from the rest of the ulna. And so very minimal secondary osteoarthritis, and it is due to this fragmentation of this medial coronoid process. The third underlying primary lesion of elbow dysplasia after medial coronoid process and osteochondrosis is the ununited anchial process. This occurs less frequently as the underlying cause, and it is recognized when the anchial process of the ulna is not fused by 150 days of age. There are certain breeds that are known to have separate centers of ossification. Those breeds would include German Shepherd dogs, Greyhounds, Pit Bull Terriers, Golden Retrievers, and Labrador Retrievers. And all of those patients will have fusion of that separate center of ossification by 150 days of age. In patients that have a persistent or an ununited anchial process not with a separate center of ossification, the clinical signs will typically develop at 5 to 12 months of age. Large breeds are more affected, and at-risk breeds are included on this slide. Of the bilateral disorders, both elbows are affected only about a third of the time. This is not usually a challenging diagnosis, and I've listed the radiographic findings on this slide. The best view to identify the ununited anchial process is going to be our flexed lateral view. And this is actually a skeletally mature patient. And the most important thing that we're going to look at is the anchial process. And when we look at the anchial process of this dog, we can see that there is a large radiolucent line that's somewhat irregular that is separating out the anchial process from the rest of the ulna, or the rest of the olecranon here. Usually this irregular line has variable sclerosis on the edges of the fragments. And then certainly this patient can develop secondary osteoarthritis with osteophytes in the sites that we've already looked at. This is that same patient we just saw on the previous slide. This is the lateral view that is not flexed, and you can see that although I can still see that radiolucent line and that separate anchial process, it is going to be more challenging to identify it due to the superimposition of the humerus and that medial humeral epicondyle. So again, with elbow dysplasia, I think it can be beneficial to get 4 views. Now, this patient also has some incongruency of the humeral radial joint here. So the cranial part of the joint is wider than the caudal part. And so that is just some elbow incongruency that can be seen with some of these elbow dysplasia problems. This patient looks like it has a normal contour of the medial coronoid process. This is a different patient that I've provided the lateral and the cranial caudal views. This patient has a large, kind of irregularly shaped piece of the anchial process that is not associated with the rest of the ulna. So there's a large, irregular radiolucent line separating out that piece of the anchial process. There is sclerosis on either edges. A flexed lateral view would probably provide a little bit more clarity of all of the structures in this area. This patient also has some osteophytes on the condyle of the humerus here cranially, on the radial head, on the kind of area of the olecranon into the anchineal process. And then this patient also has sclerosis of the trochlear notch. Notice that on the cranial caudal view, it's not going to be able to be identified that the anchineal process is ununited, although it does look a little bit irregular. But this patient does have some osteophytes and has quite a bit of medial soft tissue swelling. Finally, a quick discussion on OFA evaluation of the elbow. If you are having a client present with a patient that they want to have OFA evaluation, for the elbow dysplasia, they only look at the extreme flexed lateral views. Those are submitted to the Orthopedic Foundation for Animals to be certified in a patient that is at least 2 years of age. And I've provided the website there if you want to go and read a little bit more about elbow dysplasia and submission and grading. For these patients, elbows are graded as either non-dysplastic or dysplastic, and then when they receive a dysplastic reading, then they are graded from 1 through 3. And really the only thing that is being graded is this anchineal process and if there is new bone formation on the proximal aspect of it. So if there is no new bone and they don't identify any specific findings of elbow dysplasia, they'll be non-dysplastic. And then grade 1 is going to be less than 2 millimeters of new bone. Grade 2 is 2 to 5 millimeters of new bone. And again, we're looking at this area. And then grade 3 would be greater than 5 millimeters. You can read more about elbow dysplasia on the OFA website, or you can look at the textbook chapter and reference that I have listed on this slide.